Hi, my name is Claire, and this will be my presentation of a normal GI assessment while also discussing abnormal findings for constipation. This exam will start with an introduction of myself as well as my credentials and a confirmation or inquiry of the reason for a visit or chief complaint that the patient has, as well as discussing the plan for the visit and what the patient can have as expectations throughout the assessment. Taking note of the patient's past medical history that is pertinent for any abdominal exam, family history, as well as personal and social history. Things like this can include if the patient has IBS, history of ulcers, family history of colon cancer or disease, any malabsorption like celiac disease, and personal or social history, what the patient likes to eat, if they drink at all, if there's been any changes within their diet or mobility recently, or any stressors that they may have. The history of the present illness or the chief complaint, discussing with the patient if there's been any changes in the GI, GU, or gynecological changes, making sure to ask about the last menstruation or menses. Is the patient on any medications or supplements like steroids or aspirin or NSAIDs, any opioids, things like that, and discussing causative factors if the patient is experiencing pain. Some of the things that you can use is the mnemonic old carts to help with this assessment to really make sure you're discussing when things happened, if they're intermittent, constant, the duration, location, character, if it is frequently, consistently. Overall, if these episodes are worsening or improving, as well as there's any aggravating factors if the patient was doing anything at the time of the episode, or if it could be correlated with something they were eating or doing at the time, relieving factors, any medications or methods that could make it better. Um, and then also just having the patient rate the pain from 0 to 10, and if it is impacting any abilities or activities of daily living. Prior to the exam, have the patient empty their bladder. Having a full bladder can be uncomfortable for the patient as well as impede on the assessment. And have the patient lie in a supine position in a well-lit room with the small pillow under their head and under their knees with their arms to their side, making the patient as relaxed as they can be. Um, Drape a sheet over the patient's abdomen and chest for warmth and privacy, and then you can remove the drape from the abdomen while assessing so it does not interfere with the assessment. And then ask the patient for any areas of tenderness and make sure to examine those last. The abdominal exam has four aspects to it: inspection, auscultation, percussion, and palpation. And also, when looking at the patient's abdomen, it can either be divided into four quadrants or nine regions. And I've had both of these displayed for visuals so that people understand either using the regions or the quadrants. Begin the assessment with inspection, noting the abdomen, the skin color, and any characteristics. If there's any bruising or variations or shadows. Typically, this is started by the provider being in a seated position at the patient's side. You can also take time to notice any bruises, redness, lesions, or nodules. Some unexpected findings are jaundice or cyanosis, ascites, Sister Mary Joseph nodule, and Cullen sign. Next, you can inspect the contour of the abdomen. Is it symmetrical? Is the umbilicus located centrally without displacement, free of redness and inflammation? You can move to standing by the patient's head, noticing any distension or bulges. If you do notice distension, is it symmetrical in location? And then having the patient lift the head, you can examine for any hernias that could protrude at that time. And then also observing the patient's movement while they're breathing if it is symmetrical. Auscultation occurs prior to percussion or palpation to ensure that the bowel sounds do not change throughout the assessment. Place the diaphragm of the stethoscope on the patient's abdomen, ensuring that the stethoscope is warm. Listening to bowel sounds, noting their character and frequency. Some variations may be long, prolonged gurgles, increased bowel sounds, high pitched tinkling, decreased sounds, or absent sounds. Absent sounds do require listening for 5 continuous minutes, and typical bowel sounds can be heard anywhere from 5 to 35 minutes. Listening with the diaphragm to note friction rubs over the liver or spleen. These can be heard with high pitched and with respirations. A bruit sound is a harsh or musical intermittent sound. Finish by using the bell of the stethoscope at the epigastric region and the arteries. Vascular sounds are well localized. Auscultating with the bell at the epigastric region and the umbilicus for the venous hum, which is a low, soft, and continuous noise. Auscultation is the next portion of the exam. You are noting vowel sounds using the diaphragm of the stethoscope. You can note the character and frequency, as well as if they are high pitched, prolonged gurgles, increased, decreased vowel sounds. If you are not hearing vowel sounds or have absent vowel sounds, you need to listen for 5 continuous minutes. Typically, vowel sounds can be heard anywhere with 5 to 35 per minute. Over the liver and spleen, noting if you hear a friction rub to that. A friction rub is a high-pitched noise with respirations. Finishing by using the bell of the stethoscope at the epigastric region to listen to the epigastric region and arteries, noting if you have any venous hums or low, soft, and continuous noises. Percussion is the next aspect, and it is used to assess the size and density of the abdominal organs and can be used to detect fluid, air, and masses. There are different notes that are tympany, hyperresonance, resonance, and dullness. You can start by percussing all 4 quadrants of the abdomen on the patient to give you an overall sense of tympany or dullness. And then specifically, you can also percuss the liver span to give you an estimated size of the liver, the spleen, gastric bubble, and the kidneys as well. The kidneys typically are examined by having the patient sit up, and so this can be done while assessing the patient's back as well. Palpation is performed to help assess the organ size, shape, mobility, and consistency, working from light palpation towards deeper palpation. Light palpation is done by laying the palm of the hand lightly on the abdomen with fingers extended and held together, pressing no more than 1 centimeter using light, even circular motions. And this can be used to help identify any muscular resistance. Moderate palpation is done with the same technique, but exerting more pressure. You can use the size of your hand as a maneuver to help identify any organs that move with respiration. Deep palpation is done by using the palmar surface of extended fingers, pressing deeply and evenly into the abdomen to note any or help detect less obvious masses in the abdomen. If you do identify a mass, make sure you note the size, shape, consistency, tenderness, mobility, and movement with respirations. And then palpating all 4 quadrants. The chart here has the anatomical positioning of the organs and continuing to monitor if you notice any discomfort or tenderness. And then typically you are not able to palpate organs like the liver, the gallbladder, and the spleen may be felt if it's enlarged. And then more often, the right kidney is more commonly palpable than the left kidney. Okay, so we begin by inspecting the abdomen with the patient laying down, so you can uncover part of their abdomen. Taking note on the symmetry of it, as well as the umbilicus, if it's located centrally or displaced at all. Noting any rounding to the abdomen or contouring, discoloration. There's no bruising, discoloration, slightly rounded. And then our other thing that we can do is note venous return and any surface motion as the patient's breathing in, taking note the symmetrical rise with respirations. If the patient raises their head, you can also be using that to detect masses or hernias or the separation of muscles.
The second step that we are doing is auscultation with the stethoscope, using the diaphragm of the stethoscope, listening to all four quadrants for vowel sounds. There could be anywhere between 5 to 35 vowel sounds per minute. Taking note of the sound that the vowels are making. And no abnormal findings with that. Switching it to the bell side. Listening for vascular sounds, for any bruits that may be present. There are no bruits or abnormal findings with that. The next step will be percussion, and starting with using either the four quadrants or the splitting it into 9 regions. You can percuss around the abdomen. We're going to use the 4 quadrants and get an overall sound of the abdomen for tympany, resonance, dullness, taking note of what you're hearing. Any gastric air bubbles or things like that. Noting the liver span, the change of tympany to dullness, as well as the spleen, noting that as well. The last portion is palpation, starting with the lightest touch, using the palmar part of your hand with the fingers extended, and starting with light, you do small circle, circular, 1 centimeter depth of palpation, noting the patient if they have any tenderness or grimaces on their face. And then you can move up towards moderate or deeper palpation using either the side of your hand or just progressing in depth. And this is where you could note some discomfort from the patient or tenderness. Also, you can check for rebound tenderness as you remove your hand. And you can also use the percussion to feel the masses or the organs to feel if there are any abnormalities.
For someone with a chief complaint of constipation, some things that might be noted is you may be able to palpate a fecal mass, which may have a soft, rounded, boggy mass in the colon area. Stool could be noted in the rectum, decreased vowel sounds, and then pain characteristics like colicky, dull pain that is steady pain that does not progress or worsen. With history for presenting illness like constipation, the character that may be presenting as abdominal pain, discomfort, blood in the stool, or diarrhea, bloating, and gassiness. You should know the pattern of the last stool, the last bowel movement, any change in size or consistency, or pain with a bowel movement. Noting the patient's diet. Is it a high fibrous diet? What does their fluid intake look like? And any recent diet changes. Are they on any medications like laxatives, stool softeners, iron, diuretics, or opioids? And then the lifestyle of the patient, if they're sedentary or active, or what mobility is like for them. These are the references used throughout this presentation, and thank you.